Respected chairpersons and my dear friends, we have been discussing about how stones are formed, and we have been discussing about how stones can be passed, and we are discussing how stones can be prevented. We have been doing this all along, but the ultimate answer has not yet been reached. The incidence of stone disease has been increasing over the period of time. Earlier we had only the X-rays, but now we have got more revolutionized investigating mechanisms, and microstones are recognized in the kidney. The stone metabolism is probably different in the different types of stones. The triple phosphate staghorns, the metabolic stones, cystine stones, but most commonly we are dealing with the idiopathic calcium oxalate stones. So there may be various factors which are involved. The pathology may be different, but ultimately one thing that we have recognized so far is the crystals are the sheet anchor of the formation of the stones, and they ultimately become big stones. The medical management of the treatment of stones is primarily metabolic, and what to control the metabolism is to control the crystal formation. It is generally believed erroneously that metabolic studies need be done only for recurrent stone formers, but we have found that every patient who has any suspicion of stone disease should be metabolically investigated in toto. More importantly, the crystal pattern of the patients should be repeatedly studied, because that is the most important part of the initiation of stone disease. So we have recognized that initial assessment of the metabolic status is fine with 24-hour urine and blood, but repeatedly we suggest the urine deposit. Early morning urine is far more important in recognizing the pathological crystals, and so this should be the sheet anchor of treatment, the dose of the drugs to be decided on this. The objective of this paper has been to find out the importance of assessing the crystalluria and correspond the extent of crystalluria with the metabolic status and decide how stone formation can be prevented. In this study, we have taken 350 patients who had symptoms of urinary stone disease and radiological, that means ultrasound or X-ray identified stones. And those patients requiring active intervention have been excluded from this study. The purpose was explained to the patient and consent was taken. The urine deposits, primarily we look for RBCs, oxalate crystals, and uric acid crystals. The infection stones are very rare in our area, and so that was not at all considered very important. Phosphate crystals were very few in our patients. And the metabolism was correlated with the demographic factors and the extent of crystalluria. It is very unfortunate that this picture is so rampant in our patients, but unfortunately not recognized in the laboratories. The dumbbell-shaped crystals of the calcium oxalate monohydrate. Rarely do I see a report of the calcium oxalate monohydrate, except in my own special laboratory where I have trained my technicians to identify them. We find that 33% of our patients with idiopathic calcium oxalate stone disease do have monohydrate crystals at some time or the other, and unfortunately not recognized in most of the other laboratories. A typical dumbbell-shaped crystal. The size of the crystal is also very, very important because the larger the crystal, the higher the metabolic potential for the formation of stones. Here we get aggregation of the crystals to form the ultimate stones. Calcium oxalate dihydrate is considered to be a normal phenomenon in many people, but we do not consider so. It is not present in asymptomatic 12% of the people, but if there is a large crystal or a crystal aggregation or a crystal clumping, and particularly when the crystals are more in the early morning urine, we consider them pathological. We have to consider that these crystals are the forerunners of calcium oxalate dihydrate crystals. And we have done electron microscopic studies of the urine and the stones and found that there was similarity in the three-dimensional appearances of the urinary crystals of calcium oxalate dihydrate and the crystals that they are formed. Definitely, calcium oxalate dihydrate should also be considered. We come to the triple phosphates. As I told you, it is very uncommon in our situation, but still, if there are plenty of them, we should be considering the phosphates, and ammonium urates are far more important. We do the ultrasonography in all the patients, and X-ray KUB also is done in all our patients, but CT urogram is done only in selected cases, because we personally think that it may be costly for the patient, and it is absolutely, it's not an absolute entirety as far as we are concerned, because the urine deposit is far more important than the CT scan in managing or continuing to assess the status of the patient. And chemoprophylaxis have been discussed in various forums. Here also it is being discussed, but we have found the ultimate solution for calcium oxalate monohydrate stones. We believe that the metabolism of the calcium oxalate stone is created by the crystals of calcium oxalate dihydrate, which ultimately become monohydrate. And here, the basic pathology that forms is the high oxalate level in the milieu and also the uric acid level, which is primarily responsible for the enhancement of the size and number of the calcium oxalate dihydrate and monohydrate crystals. We have also seen through our experience that controlling oxalate crystalluria with pyridoxine alone is not as effective as controlling calcium oxalate crystalluria with a combination of pyridoxine and allopurinol. Unfortunately, this has not been recognized by the rest of the world. We have seen that the extent of crystalluria can be reduced significantly by the combination depending upon the required dose and the pathological status of the patient. It is very important to adjust to the dose of the drugs depending upon the extent of symptoms and the extent of crystalluria, the size of crystals, the presence of aggregations, and so on. So assessment of the crystalluria is absolutely essential in these patients. As we have all know, the males are predominating. The age group is from 30 to 40. Most of the common symptoms, there is nothing to discuss. So we decide the dose of the drugs based on the symptoms as well, because we have found that if the symptoms are significant, the pathology also is significant. And it is either the extent, the number and size of the crystals, and also the extent of RBCs in the urine. And third and most important, that the patient's symptoms will also be controlled by a combination of pyridoxine and allopurinol. The metabolic abnormality, we have studied a lot, but the metabolic abnormality as such is not the most important part in continuous assessment of all the stone patients, whereas the deposit, urine deposit is most important. So we do not do metabolic studies routinely. We do the studies first time and then only later on if there is a recurrence. And 93% of our patients had metabolic abnormalities, and the most common metabolic abnormality was the urine oxalate level. If we consider that 40 milligrams is the upper limit of normal, even if we took it as 80 milligrams, many of the patients had high oxalate level, and it is very necessary to reduce the oxalate level, and pyridoxine is the ideal one to do that. We have not found any significant variations in the biochemistry by the administration of the drugs, but the extent of crystalluria, as I mentioned here, 62% had significant crystalluria on repeated examination. What is happening all over the world is we just do one study and then forget about it. It is not enough. I usually take 4 samples in the initial setting, early morning urine, random. The next day, early morning urine, random. This is done along with the 24-hour assessment. If you do that, we can easily identify the extent of crystalluria is very high, and we take the deposits. Earlier I have heard that people saying you should take only the supernatant. No, it's not like that. We have to take the deposits and centrifuge deposits, and they will show you a lot of important, interesting. And then when we are not seeing the ordinary microscope, we have to use special microscope and staining procedures to identify the crystals. We identified many of the crystals by doing scanning electron microscopy. Absolutely wonderful things which we identified, which were not seen in the urinary deposits of the ordinary microscope. The laboratory technician has to be trained to identify these crystals. It's most important. In spite of treatment, 7% of the patient had persistent crystalluria, and we don't go beyond a level of the dose and I don't have this courage to increase the dose beyond 240 milligrams of pyridoxine and 300 milligrams of allopurinol. Only 2% had persistent symptoms, and 95% of the patients had stoppage of the crystalluria and the ultimate increase in size of the stones. And many of the stones can be passed with appropriate dosed chemotherapy, which I mean basically 120 milligrams of pyridoxine and 300 milligrams of allopurinol. 6 to 8 months will be the time lag taken for the passage of the stone down from the kidney to the ureter, and we have avoided a large number of ureterorhinoscopies in that. The symptomatic relief is also possible without the analgesics and with the combination of pyridoxine and allopurinol, the metabolic treatment. So we would like to discuss this case as crystalluria is the most important entity in the follow-up assessment of a stone patient in the identification of the progress of stone disease. And metabolic assessment is primarily done in all the patients, but the follow-up is basically done with the crystals, the urine deposits. And dissolution of stone, many people ask me, do you think the stones dissolve? Probably not. We have done a lot of scanning electron microscopic studies on the stones which are passed, and we found that the medicine for 6 months, the therapy for 6 months will reduce the sharpening effect of the calcium oxalate monohydrate crystals, and we have seen that long term there is a dissolution effect on the combination of pyridoxine and allopurinol, the way we give. Stone prevention, various drugs have been given, but we have ultimately found that the same dose of same medicines, pyridoxine and allopurinol in lower doses can actually retain the prevention part of the stone in most of the patients. And these studies, though the small number now, I have an experience of 3, 4, 5 decades, and the effect of prophylaxis is well established. We can prevent stone formation.
Your time here.
By controlling the size and number of crystals. Thank you very much for a patient listening. The combination of drugs are useful. Thank you.